Hello there, and a very warm welcome to today's webinar. I'm Dr. Harriet Lloyd. I'm a research associate at Cascade. I'll be chairing today's session with Professor Martin Webber, which, as you should know, is part of the ExChange Wales Autumn Conference series on mental health. So we're very pleased to be joined today by Professor Martin Webber. Professor Webber is Director of the International Centre for Mental Health Social Research and Head of Social Work at the University of York. His research focuses on the development and evaluation of social interventions for people with mental health problems. Today, he'll be presenting on supporting people with mental health problems to build social networks and reduce loneliness, giving lessons for practice and research from intervention trials. Martin, I'll hand over to you now.
Thank you very much, Harriet, and thank you very much for the invitation to this webinar. Right, so I'm starting off with probably the longest title ever in a webinar, so much so that I had to decrease the size of the font to fit it onto the screen. So apologies for that, but I wanted to cram a lot in to just one title, because within this presentation I want to give you a real insight and a taste of some of the research that's underway at the moment around supporting people to develop their social networks. In particular, I'm going to be talking about three models. Two of them are being trialed at the moment. One of them has been already evaluated. I want to explore with you some of the shared and common features and differences of these different approaches to allow us at the end to draw some potential early conclusions. Now, you cannot draw too many conclusions while trials are still underway, but it does provide us with the opportunity to think about what good practice might look like, what might be effective, we don't know yet, what might be effective and what might not. And I'll be really interested in your views as well. So I do look forward to your questions and comments and discussion towards the end. Before I really kick off, though, I wanted to acknowledge the participants who took part in all of these studies and are taking part at the moment in the studies, the practitioners who are delivering the interventions and have been involved in the research, as well as all of the researchers who are involved in collecting the data. And also a standard disclosure from the National Institute of Health and Care Research, who are funding and have funded the research that I'm going to be talking about. Anything is not due to NIHR, it's all my fault. Basically, all of the mistakes are my fault. Anything I say is not coming out of their mouth, but out of my mouth. So that's the disclaimer, the official disclaimer is there, but you know what I mean. So, okay, the three approaches we're going to be looking at are social contact coaching, community navigators, and connecting people. Now, just having a quick look down the attendance list, I can see that a few of you are probably familiar with at least some of these, maybe more of them than I might give credit for. But they share in common the approach of supporting people to develop networks. And I want to start by going through very quickly some of the social concepts that we use in this space, in this area of research and practice, which we probably take for granted. But I just wanted us to take a quick step back so that we're all kind of starting from the same place and understand together exactly what these mean and what we mean when we talk about them. So we're talking about social connections, and they are undoubtedly of importance to us, partly because the absence or their absence is harmful. There's very, very strong evidence that loneliness and social isolation shortens our lives, and also that strong relationships help us to live longer and more fulfilling lives. So relationships are good for us, social connections are good for us, but not always. There's always a but and or but or when you're considering the effect of relationships on us in many different ways. Sometimes relationships can be problematic, but on average, in the main, social connections are less harmful than the absence thereof. That was a really complicated way of saying it's good to be in touch with other people. It's good to have contact. But many people don't, and this is really what we're trying to address. Loneliness has become much more prevalent since the pandemic. Lockdown has enhanced feelings of loneliness, but also in the public consciousness, we've become so much more aware of it. We've had in England a loneliness czar. I don't know if they're still in post, but certainly it was the focus of somebody's job to pull together policy and practice around loneliness. And it's an undertone in terms of contemporary social policy that this is an issue to be addressed. The surveys indicate it's not necessarily going down. It's been particularly problematic amongst younger people during the pandemic and since. So it has a harmful effects. But just as I talk very quickly about what loneliness is, it's important to bear in mind that it's a subjective experience. It's a feeling. It's an emotion. It's different for different people. It's a subjective state. So the old adage that you can be lonely in a crowd is very, very true. You can have connections, but you can still feel lonely because it's this perceived deficiency in your social relationships. You might have contact with other people, but they may not be giving you exactly what you need. And loneliness is an unpleasant and distressing experience. We talk about loneliness and social isolation often in the same sentence, and I'll be doing that repeatedly over the next half an hour or so. But they are conceptually different. Loneliness is that feeling. Social isolation is the much more kind of objective measurement of being alone. So it's much more to do with the absence of social interactions or contact with other people. And you can choose to be alone. Of course, you can choose to be alone. By nature, I'm an introvert and I don't mind being alone for long periods of time. That is partly a choice, it's partly a personality feature, but many people choose to be alone, choose to be isolated, and they're absolutely fine with that. Also, many people don't choose to be alone and they are forced to due to circumstances, due to a whole series of different reasons. And that's where loneliness can potentially creep in, because they may be wanting more contact with people, but not able to have that for different reasons, as we'll explore. So loneliness and social isolation are different, but they are definitely connected. Now, in social work, we have as one of the kind of the fundamental social science concepts of social support, which we kind of talk about all of the time, but we rarely take a step back and actually break it down and think about it in terms of what that actually means, because I think it is really important because it is so all-encompassing. It really does embrace a number of different dimensions and concepts, which we all need in our everyday lives. And many of us can get by without some of these, but at some point during our life, we kind of need all of these. Emotional support is important. We take that for granted on a day-to-day basis. If you're living in a family or with partners or with others, care, love, empathy that we receive is really, really important. Instrumental support is around the practical support that you might get from other people every day, or information that you might obtain through your networks or through other people, just helping you, nudging you, giving you a little bit more help along the way. Appraisal support is very much in relation to how you evaluate yourself, either with peers or with others. You're checking in with others about how you're doing, how you're matching up to others, and so on. And the companionship aspect of just being around other people is obviously really important, and undertaking activities is often much more fun with other people than undertaking it alone. And we need different elements of these of the concept of social support at different times, of course, and you can get on without needing all of these all of the time. Also, it's reciprocal, so it's not all about receiving. In our relationships, we give back, and in order to receive, we need to have that kind of give and take to maintain the relationships. The important one for mental health, though, is the perception of social support. If you're feeling that you've got people around who you rely on, who you can obtain support from, then that is positively correlated to your mental health. It's good for your mental health. This has been seen prospectively over time as well in longitudinal studies. People with perceptions of stronger social support improve mental health over a period of time. There is a reverse causality in some of these relationships as well, where people with depression may perceive lower levels of social support. That absolutely is observed. But even within people with those diagnoses and experiences who perceive more social support tend to have a better prognosis, tend to have better outcomes over a period of time as well. So it does have that longitudinal relationship as well as a bidirectional cross-sectional relationship. So it's important for us in summary. And the other concept which I'm going to be banding around really kind of quickly. So this is the longer form of what I'm meaning when I'm talking about social capital in terms of the resources that are within our networks. It's very much linked to social support and that concept, but here it's about the extent to which you can gain access to different sets of resources within your networks when you might need them. This includes things like access to people in positions of power and authority who can potentially change things for the better at a different kind of level than providing one-to-one support. But it does include access to some of the more practical aspects that you would obtain from your networks. In terms of measuring social capital, it's dependent on who you are connected to, the resources that those people can access for you, the strength of the relationships that you have with those people. And also, again, it's the concept of reciprocity, because your likelihood of accessing resources from your networks is very much dependent on whether or not they can provide them to you. They're more likely to provide them to you if you also provide them with resources. So as we know with relationships, there's the give and take, there's that reciprocal element. So it requires a resource of yourself to invest in them. And it's not just neutral that you're always taking from them. The concept emphasizes the importance of both ties which are stronger and weaker. So the weaker ties are those such as neighbors, colleagues, acquaintances, people that you might come across and see every now and again, and you might just say hello to in the street, but are giving you something back in terms of just even recognition, and that's good enough. But we get a lot of informational support, and we find out a lot of things through our weak ties. Social media is great for kind of weak ties, connecting us up with people that we don't have that intimate relationship with, but might link you up with something that you know about. I'm sure many of you found out about the seminar today through weak ties, unless you're all within Cascade and you all know each other already and already have those strong ties. I don't know, but generally social capital helps you to get on and get ahead in your life. It's kind of a good thing that adds value to the more intimate relationships that you have. So by way of that rather long introduction and preamble, I'm going to talk about the three intervention models, because they're all kind of targeting something slightly different. One is looking at loneliness, one is looking at social isolation, one is looking at social capital. So the methodologies of the interventions and the practice might be quite similar, but they are really targeting different aspects of those social constructs. And as if we need a reminder, there's lots of evidence, and I've just cited a few here to illustrate what the problem is that practitioners are trying to address. Loneliness is highly prevalent amongst people with psychosis, for example, who tend to have smaller networks. Social isolation increases the risk of suicide as well as decreasing length of life. It increases mortality, for example, for a number of reasons. People with disability, including those with long-term mental health problems, experience greater loneliness and social isolation, perceive less social support. And the corollary is true, as I mentioned at the beginning. Emotional social support, perceived social support is really important for your mental health, and social capital is associated with both better physical and mental health. again, reverse causality plays a part within some of this. It's important to be aware of that. So the first one is called social contact coaching. This falls within the SEEN program study funded by the National Institute for Health Research, Health and Care Research, program for applied research. And it was a program of studies. And we're now at the very, very end of the, I was going to say the final program, final study. It's the penultimate study within the program. The final one is around dissemination, and we're not quite there yet because we're waiting on the final results. But what we did was to take an intervention where there is randomized controlled trial evidence of effectiveness, albeit in Italy, and have adapted that to utilize that for use in community mental health teams in England, is where the research has been conducted. All of this research has been conducted in England. The aim is to improve social networks and quality of life for people with psychosis. This group has been chosen in particular because tending to have smaller networks, poorer health, and of the connections between social relationships and health, it was felt important to see whether or not practitioners can increase their contact with others to reduce some of that isolation and reduce some of the consequences that come from that isolation as well. The theoretical underpinnings are very familiar to anyone with a social work background, or indeed anyone with a mental health background, as it's about taking a person-centered approach focused on the individual, their needs, goals, and aspirations, working at their pace and very much attuned to the need of the individual. Motivational interviewing as a way of assessing somebody's motivation, testing out the motivation for change, also looking at issues, barriers, and problems, things that might get in the way of achieving that change in somebody's life, and using a solution-focused therapy approach to overcome some of those challenges, really looking at a positive outcomes-based and solution-based approach. The way in which it works is over 6 sessions over 6 months, and it's delivered by people who are already working within mental health services with that professional background and experience from a range of different professions, but have experience of working with people with psychosis who've attended additional training for the intervention. So the breakdown of the content of the sessions, the first 2 sessions go through certainly the first 6 of these items within the process, and would consider 7 and 8 as well, although some of those might be picked up in the follow-up sessions. So the first 2 sessions is really establishing what it's all about, introducing it, clarifying what it is, what it isn't, exploring what the person has been doing in the past in terms of activities and what they are doing at the moment, what they might like to do in the future as well, assessing motivation for change, using some motivational interviewing to work through with them about their potential ambivalence for change and some of the issues and challenges and barriers they might have, what options are available to them for undertaking activities, providing information, and then supporting them to make a decision about what the next step would be, agreeing some actions to take. It's a coaching type of intervention, so it's up to the person themselves to then really go off and do something as a result of that discussion, those conversations, and the actions. In the follow-up sessions, the role of the practitioner is to provide kind of support and encouragement, checking in with them, seeing how it's going, and keeping them focused on what they had agreed to do. But it's really up to the person themselves to do it. The practitioner isn't going to go along with them. They might help and assist them with something, but the main aim is it's based on activities that are available in the community for anybody to undertake. It's outside of mental health services, not exclusively. It could be other activities that are put on within, but typically it's going to be beyond mental health services. That's the aim of all of these, with the aim that the person can go independently, or certainly independently, by the end of the 6 months. And through that, they are having contact with other people. So the aim is to increase social contacts. So as I said, this is part of a program of research, and some of the earlier parts of the program, we published a few papers from that. So we've got a few early findings around the area of social isolation and psychosis more generally. So the first of these three is a focus group, an interview study looking at people's explanations for their social isolation, and they attributed it partly to institutional factors in relation to potentially long hospital stays or the nature of mental health services themselves. Quite an interesting critique on the kind of the structures and the ways in which mental health services almost kind of like sought to separate people, which is quite an interesting observation. The symptoms of psychosis, and particularly those with enduring psychosis, who've been perhaps symptomatic for many years, or been in the mental health system for a long period of time, and stigma that's associated with that. So there's the internal and external factors which are causing isolation. But at the same time, people living in communities or neighborhoods that are accepting of them and welcoming of them definitely report feeling, more accepted, more able to join in and to engage with groups that other people can as well. And then we also conducted a survey of people with psychosis to explore at a much more broader level exactly what's going on. And the first one we found was that the majority of people with psychosis want more social contact. So this issue about choice, I mean, 68% is, it's over 2/3, so it's quite a significant majority of people are not choosing to be isolated. So they are wanting more contacts, which is a good thing, it's a good starting point for this type of work, because it shows that people want to engage with that kind of support. And interestingly, in this survey, we looked at kind of lower local area population features to explore some correlations in the data. And we found in particular high population density areas, in particular in high population density housing estates in urban areas, was actually associated with having fewer social contacts in this particular sample. It's people with psychosis, and here in more densely populated areas, they're tending not to have more contacts, which is really quite interesting. So it's not about rurality here, and these are in the most kind of densely populated areas, but they are not having contact with other people. So they're locked away in their home for long periods of time. And that's interesting background in terms of helping us to frame what we're doing and not to make assumptions about some of the people that we're working with. So the trial is still underway. We're very close to our primary and endpoint, and that analysis will be hopefully available to us in the next couple of weeks. But we have been working through COVID. We adapted online during COVID, and recruitment carried on. The intervention delivery carried on during COVID, but we all just worked remotely and went online with a lot of what we did. Very large sample across many sites across England, which is really helpful for purposes of generalizability a bit later on. Hopefully we can say that we've got a good cross-section of this population, all people with psychosis receiving care in secondary mental health services. They were individually randomized to this intervention, which I've described, or to just receiving an information booklet in addition to their care as usual. Primary outcome we're using is quality of life, measured using the MANSA at 6 months after baseline, which is the end of the intervention period. But we're also following them up at 12 and 18 months to have a look to see what's happening in the longer term. It's quite understandable that not a lot might happen in that first 6 months, but things might happen later on. And where people may go along and try something, they might be having some social contact, but the relationships may not develop unless they're engaging with something on a longer term basis, and then that might then have a knock-on effect on quality of life over a longer period of time. So you can imagine how long this takes in terms of going through all of the follow-ups, and we're now at the point of the final follow-ups, and the process evaluation is being completed as well. So we should, over the next 12 months, certainly have some findings to report. So apologies, I don't have those to report today, but hopefully you can look out for the papers, and they'll be published in due course. Okay, the second one is around community navigation. Here, the aim is to reduce loneliness, people with depression, and I've put treatment-resistant depression in inverted commas, partly because I don't like the phrase, and it's kind of what we're working with, but the definition is people who have received at least 2 antidepressants and their depression is not being alleviated, that they're still severely depressed. They're receiving care and support from community mental health team. Many have suicidal thoughts. Many of them might have additional diagnoses such as personality disorder, for example, or bipolar. As long as it's not their primary diagnosis, they're basically eligible for this trial. The navigators work with people to map their social worlds in a broader sense, not just people that are involved in the networks, but places that they go, activities that they do as well. And through that, they develop a personal connections plan with the aim of increasing their social connections. So it could be new social groups or reconnecting with people that they were connected with in the past. And the navigators are providing support to enable them to enact the plan. That's the aim of the community navigator intervention. In a way, it's similar to what social prescribing link workers do in primary care, but it's probably longer and more intensive than what they provide, because there's up to 10 individual meetings over an 8-month period. And there's also group meetups. Other people who are part of the trial can get together in groups. Again, it's all optional if they want to, if they find that will be helpful. So there's an additional meeting point for social contact, and also exchanging kind of hints and tips about what they've done and what works, what doesn't work for them. It kind of uses similar techniques as the social contact coaching in terms of a solution-focused and a problem-solving approach to firstly break goals down into kind of manageable chunks, smaller steps, but also in terms of addressing barriers, things that might get in the way of connecting up with others and trying out something new. There's also the provision of some modest financial support. We're not talking about a lot of money here, but it's really just a little bit to overcome that barrier of not being able to pay for a coffee in a cafe or access to a leisure centre or something like that to go swimming. So there is a little bit of a budget attached to this as well, which helps overcome some of the barriers posed by poverty, low income as well. The feasibility trial of community navigators, which has led to the trial that we're working on at the moment, had positive findings. I guess I wouldn't be here talking about this if it didn't. So it found a high interest in the programme. They recruited 40 people for the study, and that recruitment happened quite quickly. I think it was a 4-month period in which they recruited that across a couple of sites. And the retention and outcomes data was good in the feasibility trial. It was all possible. It all kind of worked, and the intervention itself was manageable for the community navigators and was acceptable. And the outcomes were positive. It is not powered to find a definitive effectiveness kind of outcomes. That's what we're looking at the moment, but certainly the outcomes were positive of that, enough for us to be able to progress on to the full trial. Qualitative feedback from the participants again indicated that they found it helpful in developing their social connections. So the feasibility trial kind of provided that evidence to support NIHR's decision-making in funding the full trial, which we're working on at the moment. The aim is to recruit 306 people for this, and so far we're up to about 176, probably up to 180 by now. And again, it's an individual randomized controlled trial where people are either receiving the intervention or an information booklet with care as usual. Here we're looking at reduction in depression as a primary outcome, but loneliness is one of the key secondary outcomes with other social outcomes as well. Main follow-up is at 8 months post-baseline, which is the end of the intervention, and then another one at 14 months, so 6 months after that. Generally, so far, we found a good engagement with the intervention, but again, it's too early to tell as to whether or not it's likely to work. The key thing with the community navigators is that they are people from the local community. They may have some background in mental health work, they may have a mental health qualification and experience, but predominantly they are people with lived experience or local knowledge who can bring that into their work. They're additional members of the community mental health team. They're not already there. So within the trial, they're funded as additional people in the team just to do this work. And they're on a sort of a grade of a support worker kind of grade. So the final one is connecting people, which is slightly different, but also slightly similar at the same time. This is a model which is integrated into routine practice. So it's not having special people doing this work. It's about aligning the work with everyday work, effectively, with everyday practice. It focuses on co-production of the worker, the service user, in identifying new activities to undertake, with responsibilities for both the worker and the service user to provide input into the process. It acknowledges the barriers that both might face to undertaking that, and a large part of the process is focused on overcoming those barriers. It's a systemic model and emphasizes the role of the team or the agency as integral to the success of the intervention, and the embeddedness of the team in the local community is vital. So community engagement is a key aspect of this model. The intervention itself is flexible, can be adapted according to the context, doesn't have any kind of set number of sessions, but there is a process which we've developed to kind of make it more straightforward. We've made it more straightforward because this is the intervention model, the theory of change, if you like, and as you can see, it's not exactly straightforward. It's very busy, isn't it? There's lots going on there on the screen, but it's fundamentally got these two circles which are going around in the middle, the green and the blue one, emphasizing that the practitioner, service user, or it could be two peers working together effectively, it could be a peer worker, it could be anybody, both undertaking activities. On the one hand, it's about trying out new things and developing new activities in the community. On the other side, it's about developing that local knowledge, engaging with people, building relationships in order to facilitate that. The bit in the middle is the co-production bit around facilitation. I haven't got time to really go into this in depth, but just to say the two little circles going in the opposite direction are the barriers, and the barriers are explicitly acknowledged as frustrating the movement of the bigger circles. What might happen or what might not happen is that somebody's social network could be enhanced as a result of it. So the outcome is not in a straight line. It's very much as a circle in one corner, and the other corner, it may hit it, it may not. And the role of the agency is there, as I mentioned about it being a systemic kind of model. But as that is kind of like so whirly squirrely all over the place, a little bit complicated, we've provided training in much more of a step-by-step approach. And this again is very, very similar to a model of assessment, care planning, reviewing, very similar to the other intervention models in terms of a process involving mapping, making plans, supporting people to put the plans into place, reviewing how those are going, assessing what the barriers are, working around the barriers. But this additionally looks at the role of the organization and the team in terms of its location within local communities, but also its culture, attitudes, and so on to the process, which is really, really quite important. And also embedding research into that process of reviewing the whole thing. Is it actually making a difference? Is it worthwhile doing that? We developed that model through quite a substantial ethnographic study, looking at health and social care practice across the piece, very, very broadly to identify what good practice looked like. And the model has really pulled together all of the aspects of that study. So all of those words that featured on that very, very busy slide is the findings of the qualitative study, which have been modelled together in that way. And when we piloted it, we found positive findings. So we piloted it in a quasi-experimental study where all of the agencies involved in the training were in the study were provided with training, and we divided them according to the extent to which they were able to put it into practice. So we had a high fidelity group of those that were able to implement it, and those with low and moderate fidelity that struggled to implement it so much. Followed up people over a period of 9 months, and the headline findings were about an improvement in access to social capital. So again, it's a slightly different social concept, as I mentioned. This is about the resourcefulness of people's networks. So it was dependent on contact with others, but also on contact with people who have resources which are of value to the individual, and also improved mental well-being in that group. But what we then went on to do was to look at this in particular in community mental health teams, because they had really struggled to implement it in the previous study. We wanted to just focus on them. So we undertook a controlled study looking at community mental health teams, and specifically whether or not they were able to implement it. Cutting to the headline finding here, basically they struggled to implement it because of the nature of the work that they were having to undertake. Crisis management, a lack of time. This wasn't afforded a high priority within the team. Also, we were dealt a raw deal effectively because we measured whether or not the implementation teams and the control teams were in a position within the teams to implement evidence-based interventions. We found that the control teams were actually in a better place than the intervention teams to implement interventions. We didn't randomize them. They were selected for us. And that was the problem. If we had randomized them, we might have had a better outcome. I don't know. But we didn't find any differences. But there was a trend, a non-statistical trend. This is partly, I think, due to the nature of the NHS at the moment, but also over the last few years. But also it's about the culture and climate within the teams, and that's effectively what we were trying to change, trying to address. But we needed a lot more than what we were able to provide in order to change that. So just wrapping up, looking back over these 3 experiences or sets of experiences, what can we take from this in terms of social interventions within mental health services? Firstly, there is a very, very clear need and appetite for social interventions. The recruitment in these studies, I mean, it takes a long time, but we get there, and there is certainly an appetite for this kind of work because there's not a lot of it around. The mental health services are really oriented towards biomedical models, and that therein lies the challenge. The workforce similarly is oriented towards that. So social workers employed in community mental health teams are undertaking care coordination roles, which are pretty generic roles alongside nursing roles. And even social work practitioners may not have the kind of the skills, training, aptitude to lead, even not implement, but lead these types of social interventions. Also, the local knowledge and engagement of the local community is really important, and that's often lacking as well. People might work in a community but know nothing about it. So the community part of community mental health team is just meaning outside of hospital rather than being embedded within and part of that local community. I'm coming up firmly around to the idea that it might require specific people to do this job, so that it's got a focus, and also that you can employ people with that particular local knowledge to bring that into the work and bring that into the team. But at the same time, it's not a role that anybody can undertake. It requires that particular way of developing relationships. There's an element of flexibility and a way of building relationships outside of the team with the local community to support people to engage with that. A couple of other points before I close. The interventions themselves are complex. We don't necessarily know, first of all, in terms of the two trials, what element of them, if they are successful, make them successful. So although we've got intervention models and program theories, it's difficult to necessarily pinpoint any particular element. It's the combination of all of them probably that's going together that's making a difference. So replicability relies upon putting the whole thing into practice, which, as we know from implementation studies, is something of a challenge. But again, you've got to do that. And the role of the team is really important in terms of providing that support for the interventions. It's not just about individuals. Ending on a positive note, policy in England in particular is orientating itself much more towards place-based services. We've got integrated care boards, which is connecting up the statutory voluntary sectors. Also, at the same time, though, you need to do community engagement and community development work in parallel to this. So the big movement around social prescribing has been critiqued because it's very much around moving out from primary care or statutory services into the voluntary sector, whereas our approach, and another study is looking at community enhanced social prescribing, where we are working with a community and kind of doing some community development work alongside the social prescribing intervention, so that the two kind of meet together. And it really, I think, a blend of approaches is required, where you've got a systemic approach looking at the effect of the whole system, not just of one-to-one individual practice, although that is important as well. The involvement of the team, so knowledge is held within a team, connections are held within a team, not just one individual, because if they were to leave, then that knowledge would go with them. Community engagement is important. Having leadership, strong leadership is important. Specific training, a focus on this area of work, some sort of process or a program to follow is also helpful, and an attention to fidelity. But before I kind of sell this to you all and get you all signed up, we need to stop. We need to learn from the evidence, wait for the results of the trials to come in, and then we can kind of progress onto the next stage. Thank you very much.
Thanks so much, Martin. That was really, really fascinating. Thank you. We've had a few comments in the chat already. So yes, so if anybody wants to sort of leap in and ask these questions directly to Martin, you're very welcome to do so. Otherwise, I'll just carry on. So Young Chow has asked about what you mentioned about higher density populations not leading to more social contacts, and whether that might be to do with immigration or maybe sort of fast turnover in those areas. If you've got any thoughts on that?
It really puzzled us. As we wrote that paper, we didn't have any firm conclusions as to exactly what was going on here. We thought it was much more about what is happening within those areas at a contextual community level, rather than necessarily about any individuals who are living there. It could be to do with immigration. I wouldn't like to hazard a guess around that. One thing, well, it could be a number of different things. It could be around assumptions that people are making around people who are living in those sorts of areas. It could be to do with the concentration of housing within particular areas and social housing within those areas. So it could be to do with poverty and social deprivation, perhaps, and therefore people may not have the resources to go out. It could be to do with inequality. It could be to do with I was going to say violence within the community, but I don't want to kind of stigmatize particular areas of high density housing. But it could be to do with the fear of going out for some people who've had particularly harmful experiences of discrimination because of enduring mental health problems, may actually feel safer at home, and that might be going on as well. As always with this, I think we need to dig down and find out exactly what is happening. We don't really know. These are just assumptions.
Okay, thank you. So another one from the chat then. So Bex has asked about the buy-in from the community mental health teams. And I was sort of interested in that as well, and whether it was different across the different interventions. I guess particularly with the connecting people, it sort of involved them a bit more closely.
Yeah, it's a really interesting one. I think partly it depends what you're asking people to do as to whether or not you get the good buy-in. If they feel that somebody else is doing that, they can support it. If it means that they have to do something additional, then that is a bit more of a challenge to get their buy-in. The particular teams that we went to, particularly with the Connecting People study, often were either identified by the research and development department or by other senior managers as needing a little bit more input or needing something, and felt that, oh, research would be a good thing for them to do. And some of the teams felt put upon in that sense. They didn't have that buy-in. And we didn't interrupt that. We kind of just went with the flow because we wanted to see what would happen in situations where people were given this and what were their experiences in responding to it. Would they implement it or not? It was quite a neutral kind of approach that we took. On the other hand, where it was effective, and particularly in the earlier study where we did have a very good buy-in, we worked with some occupational therapists who were embedded within the local community, had really good connections with the local churches, the local mosques, the local community centres, really knew what was going on and were connecting people in at that kind of level. So it really does vary. If it mapped into what they were doing already or closely aligned to their practice, absolutely good buy-in. But if it was not kind of within their purview, then yeah, as you're saying, Bex, in the question in terms of medical social models, that did vary. If the team had a much more of a social model orientation already, yeah, buy-in wasn't really a problem.
Okay, great, thank you. And so go to Tony's question in the chat as well, which was about so the Community Navigator trial ran over 8 months. Were their outputs measured at midpoint and the end? And if yes, how did they compare? Was the longer duration of the intervention more successful?
I can't comment on findings because we're still recruiting and we're still collecting data. So we haven't done any analysis yet. It's all being collected. We had an interim follow-up at 4 months, which I didn't mention, because it's only collecting a couple of the outcome measures, and it's more of a way of checking in with people. What we're anticipating is, and because we're kind of putting a lot more weight into getting the 8 months follow-up data as our primary outcome, we're anticipating a greater, more complete data set. I think we've got about 75% follow-up so far on that. So we will have a better follow-up at that point. I also think it's unrealistic to assess outcomes midway during the intervention, as I said, because over a 4-month period, things might be starting off, but you've got to allow it to take its course. And people have also got to be allowed, the opportunity to try out different things that may or may not work for them. And sometimes they might find something that works for them towards the end of that period. So it might be captured by 8 months. And I think the 14-month follow-up is potentially going to be more useful in terms of what sort of things are enduring. The problem with trials is that they're funded for short periods of time, albeit they're very expensive, and it takes a long time to get to that. But the follow-ups are typically relatively short, which means that you don't know what happens to people on a longer term basis. You're only recording those outcomes for a matter of months, which has some value. It tells us the immediate impact. It doesn't tell us that kind of enduring value. I'd really like to come back to the participants and see how they're doing further down the line. Tony, you've got your hand up, so I guess I don't know whether I'm answering your question or not.
Can you hear me?
Yeah.
Yeah. It's really interesting. I only ask because we provide a lot of services like that ourselves in the British Red Cross. Commissioners tend to, when you have an SLA, the service, the duration of contact with an individual is much shorter than 8 months in general. And I'm quite interested because I think we're asked to demonstrate, outcomes over maybe 6 to 12 weeks.
Yeah.
And I think that's really difficult. And then you're saying you're looking at 8 months and then 14 months. And I think that maybe the commissioning practice and commissioner sort of objectives and outcomes aren't really, that they haven't really been thought out in relation to individuals.
Yep, that sounds very, very similar to our social prescribing link workers who are expected to undertake the work in, 6 to 8 weeks, perhaps. And in my mind, that's enough to solve an immediate crisis or signposting people in the right direction. The benefit of this type of intervention is that it provides much more fundamental support to engage people to develop those new relationships or attend those groups or be part of the local community. And to troubleshoot with them when they have difficulties with that process, work through them with that. It feels like that proper type of intervention. And yeah, I completely agree that services are often commissioned on the basis of throughput, so that you get a lot of people seen very quickly, and you're quickly closing them. What we're hoping with the cost effectiveness analysis of this intervention is that it will show, hopefully, that spending more time with people and working with them over a longer period of time will be cost effective as well in terms of improving outcomes.
Oh,
yeah.
Hopefully that will change commissioner behaviours and the sort of propensity to commission a service for 12 months and that's it.
Yeah.
So it's really, really difficult as a supplier, I'd say, in that sector. Thanks.
Okay, thanks. And just I can respond to Hannah's comment. It sounds like a local area coordination. Yes, absolutely. There are so many of these types of interventions that kind of map onto each other. They're all taking a common strengths-based approach, and they've got slightly different emphasis. So local area coordination is a slightly different emphasis than some of these. I haven't talked about social prescribing link working. I mean, that doesn't typically happen within community mental health teams, although it does in some places. And the community navigator approach is a similar type of approach, but very much embedded within secondary mental health services.
Thank you. Can I ask a question then, if there's not another burning one for at the moment? So I was just wondering about the coaching, and I know it's kind of person-centered and sort of dependent on what people bring to it, but I was wondering about kind of if it's just geared towards meeting more people and making more sort of contacts, or whether there is stuff around how people build relationships kind of longer term, and kind of if, you know, the things that they're sort of experiencing mental health wise are preventing that in some way, that's being addressed as well.
Yeah, absolutely. You can't just develop an intervention which doesn't focus on that, because the impact that psychosis has on people is absolutely fundamental, and particularly this group of people who have been in community mental health teams for a long period of time. Their relationships have been quite severely impacted by that. So a lot of the conversation in those sessions is around the impact of their diagnosis and experiences on the relationships, how they've managed them in the past, what they might do about that in the future, issues of disclosure and so on. Yeah, it's got to look at that in the round.
Okay, that's really interesting. Thank you. And just I know you sort of mentioned briefly how hard it is sort of teasing out the impact of different aspects of the interventions, but obviously you've got in one of them the kind of the group element, and obviously, you know, you were mentioning this sort of feedback about it being quite an isolating experience going through mental health services. Are you able to kind of tease apart to what extent they're forming social connections through that as well?
Again, unfortunately, it's too early to say. In the feasibility study, that was kind of added on as you know, it was tried out, it was suggested, it wasn't part of the model originally, it got added in because the participants wanted to connect up with each other to do that. So there's obvious benefit and value in doing that, but the intervention itself is aimed at supporting people to move beyond their contacts within mental health services. So it's very much as a kind of an interim or a partial support measure. We will know more when the process evaluation is done. We can find out whether or not it is an important integral aspect of the intervention, or just something which some people value.
Okay, thank you so much for that. Really, really informative. Martin Webber will be happy for us to circulate his slides, and we'll keep an eye on the reports as well, and circulate them when they're published, if that's okay. Many thanks again. Thank you.
Thank you very much.